So most of my talks, actually all four of my talks have been cardiology literature updates to a large extent. And this is labeled cardiology literature update, but really this is just a kind of a potpourri of a few additional topics that I'd like to address before we close things out. So a little outline. We're going to talk about 4 articles in this talk. One that pertains somewhat to education, and then we'll talk a little bit about presyncope, just a real quick, simple article on presyncope versus syncope, and then 2 ECG topics just to finish things up. Before we get into the syncope and ECG topic, though, I want to introduce the first article based on an email. This is a type of email that I oftentimes get, and something that I'm sure many of you may relate to as well. The email usually goes something like this. Hey, Amal, I was at a conference recently and you were talking about this, or maybe Haney or someone else was talking about this topic. And I told my cardiologist or my hospitalist about this new thing that you talked about, or a drug or an EKG finding or something, and they've never heard of it. And they were angry at me for even bringing it up, right? Has anyone ever experienced that, right? Raise your hands up. How many people have? Yeah, all of us, right? Everybody. And so the question is, when you hear things at conferences that are based on good literature, why is it that sometimes the consultants may not have heard of this? This is a fantastic article that was published in the cardiology journals, and what I will tell you is that there's similar literature pertaining to intensive care medicine, infectious disease, and this would probably be true for emergency medicine also. So this is not a slam against cardiology, it's just kind of a slam against medical education in general. So in this American Heart Journal article, they asked a very simple question. When a defining study, a definitive pivotal study gets published leading to a class 1 recommendation, standard of care, how long is it before the rest of society, medical society, starts practicing that way? All right? So what these authors did was they found 11 class 1A recommendations, things like using aspirin for acute MI, right? No doubt that's very important based on fantastic literature. And they went back and found the pivotal clinical trial, the study that definitively says that this is what you have to do. It's such a powerful study that it leads to the class 1A recommendation. And they asked, how long does it take from the time the pivotal study leading to class 1A recommendation is published until the majority of clinicians are actually doing that? And they said, how long before 70% of the people out there are doing it? How long before 90% of the practitioners out there are following what this pivotal clinical study ended up showing? All right? So this is a quote from out of the study. The time of pivotal clinical trial publication to meaningful uptake of class 1A. Remember, this is not equivocal. This is 1A, ACS therapies, and they just looked at ACS therapies in the clinical practice. How long do you think it took before this was widely adopted in standard practice amongst these 11 pivotal clinical trials? Give me a number. How many years did it take? 3, 2.5, 8, 10, 15, 16 years. On average, 16 years from the time the pivotal study, definitive study, standard of care study is published until 90% of the clinicians out there are using it. Let me give you an example. Aspirin, take a look down here. Aspirin, from the time that the definitive study said aspirin saves lives, it took 2 years before it got incorporated into guidelines. Okay, 2 years. And it took an additional 14 years before 90% of clinicians were routinely giving aspirin to their STEMIs. What about TPA? From the time that the definitive studies showed TPA saves lives in STEMIs, it took 8 years before it showed up in the guidelines as class 1A. 8 years of people dying before it got incorporated. They didn't go out beyond that because then cath started taking over. Unfractionated heparin. From the time that definitive studies showed that unfractionated heparin is useful for STEMI patients, it took 13 years before it got incorporated as class 1A in the guidelines, an additional 17 years, that's if my math is right, 30 years before 90% of clinicians were using it. Beta blockers, 4 years, and then 10 years before 70%. And then there's a little debate now about whether beta blockers are useful early on or not, ACE inhibitors, and so on. And they go through a whole bunch of these. But on average, it took 16 years before definitive studies got incorporated by the majority of practitioners out there. And this is not just cardiologists. These are hospitalists, probably emergency physicians, and everyone else out there. It's an enormous amount of time. So what's the take-home point? All right, the take-home point here is actually very simple. Don't get frustrated. When you learn something at a conference, or you read something that's definitive, or you read something in the national guidelines that's already Class 1A, don't get frustrated that the people upstairs don't know what you're talking about. It might take an additional 16 years, all right? But you've got to share the literature with your colleagues, because you can't expect that just because you know about it, everybody else is going to know about it. Your knowledge is based on what you've read, and they might be reading something completely different. You've got to share the literature with your colleagues in the ED, with your colleagues that are down the hall, with your colleagues that are upstairs or downstairs as well. Share the literature with them. I've said this multiple times with regards to the cardiac arrest literature and some of the other literature, because they don't know about it yet. Share the literature with them. Don't get too frustrated with them. All right, mental break. Let's talk briefly about syncope versus presyncope. First of all, has this patient been a victim of syncope? No, of course not, because he hasn't woken up yet, right? So syncope, you need to wake up and be normal. But presyncope is kind of the swoon. Syncope is easy. You're awake and alert and normal, then you're unconscious on the floor, no postictal period, brief period of unconsciousness, and then you wake up and you're normal again. That's syncope. We all have a pretty much standard workup for syncope. But what about presyncope? I got real lightheaded and nearly passed out, but I didn't completely lose consciousness. Is that the same thing or not? Well, most people don't consider that to be the same thing, but the literature says that it's pretty much the same disease, even if the patient didn't completely pass out. Back in 2012, Shammai Grossman, who's up at one of the Harvard hospitals, did one of the early studies, and he found that 20% of patients with presyncope had serious outcomes, which was almost identical to the syncope patients. And in his study, he found that the etiologies of presyncope versus syncope were the same. The morbidity and mortality of presyncope versus syncope were the same. So it didn't matter whether the patient completely passed out or almost completely passed out. And then moving forward to 2015, a more recent study, and we should have a giveaway for anyone who can pronounce this person's name, but we're not going to do that. So this is from Canada. Ian Steele and Wells were authors of this study also, Wells from the Wells criteria fame. And in this study, they looked at presyncope versus syncope. What they did, they looked at two large academic emergency centers. Presyncope, not that common, about 0.5% of patients. But what they did was they asked the clinicians, what do you think the risk is for this presyncope patient of having an adverse outcome, either death or morbidity, in the next month? And invariably, they almost universally underestimated the risk of these presyncope patients. The actual risk was about 5% of these presyncope patients had adverse outcomes in the next month. What most clinicians estimate is nearly zero, maybe 1% at the most. And so in a very, very publicized editorial written by James Quinn, who's from the San Francisco Syncope Rules, he and some of the other folks that reviewed the study said that this study shows that, number one, we need to be just as concerned about presyncope as we are with syncope. And number two, most clinicians don't tend to appreciate the risk that's associated with presyncope. The bottom line is very simple. When you see a patient that nearly passed out, you should work them up and worry just as much as if the patient did completely lose consciousness. They have the same etiologies and pretty much the same morbidity and mortality in the short term as in the long term. Do the same type of workups. All right? So, again, very simple point from that article, but I think it's a point that emphasizes again that we underestimate the concerns associated with presyncope. Okay. Let's move on to a couple of EKG topics. This was sent by Dr. Chuck Warlow, who is a clinical professor of emergency medicine at Lehigh Valley in Pennsylvania. He sent me two really interesting EKG cases, which gives me an opportunity to talk about a topic which, for whatever reason, was a very hot topic in the EKG literature over the past couple of years. It's always been an important topic, but for some reason there was a plethora of articles that got published just within the past 2 years on this. So let me present the cases he sent me. 59-year-old comes in with dyspnea on exertion for a few weeks, no pain. It's got a bunch of medical history, hypertension, obesity, anxiety, depression, and take a look at his vital signs. Overall, he looks comfortable. It's afebrile, heart rate 69, respiratory rate 26, pulse ox 92%, blood pressure pretty good, and exams otherwise unremarkable. Here's the ECG, all right? Hopefully you guys can see that. And what you probably appreciate is that there's a T-wave inversion in 3, kind of flat in AVF, and T-wave inversions V1, V2, V3, even out to V4 and V5. Here's the old EKG for comparison, all right? So all of those T-wave inversions are new. All right, so lead 3 T-wave inversions new. Let's go back to that EKG. New flip T-wave in lead 3, new flattening in AVF, and all of these T-wave inversions are new. What's the diagnosis? All right, case number 2. 66-year-old woman comes in with acute shortness of breath for 24 hours, history of diabetes, lymphedema, chronic kidney disease, recent pneumonia, chronic back pain, to the point that she needs to get around in a scooter. She had a recent pneumonia, and now she's back febrile again to 100.3. Heart rate's okay. Respiratory rate's 26. Pulse ox 64% on room air. It's a little bit better on non-rebreather. Exams otherwise non-diagnostic. Here's the 12-lead ECG. And once again, flip T-wave lead 3, flattening in AVF, maybe even a little bit inverted in AVF. Flip T-waves, V1, V2, V3, V4, maybe in V5 also. Here's the old 12-lead. So all of these, actually, I'll show you the machine's interpretation, new ischemic findings in the inferior and the anterior septal leads. Be careful about the EKG computer interpretations. As I will say, EKG computers are programmed by plaintiff attorneys. All right? So don't ever believe your computer interpretation. So anyway, here's the old EKG. So all of these T-wave inversions now are new because the old EKG had normal T-waves. So once again, here's our new EKG. Flip T-waves, inferior and anteroseptal, anterior, out to V4 and V5. What's your diagnosis here? Pulmonary embolism. All right? So the first mini take-home point, PEs can definitely produce fevers. All right? In fact, the literature has reported PEs producing fevers up to 102 routinely. That's 39 degrees Celsius routinely. All right? So don't ever rule it out based on a fever. The most important thing is the abruptness of onset, as Kevin talked about recently. But I want to focus your attention on a lot of literature which has recently been published that has talked about the electrocardiogram findings of massive PE. We're not talking about the small PEs that we all have right now, okay? We're talking about the massive PEs that make patients unstable. Here's 2 articles from 2015. There's one more that just got published in early 2016. Here's 3 articles from 2014. I'm not going to go through all the details of these articles, but I'll just summarize them all in a couple of slides. Essentially, what they say is that massive PEs are notorious for producing T-wave inversions, especially in the right precordial leads, V1, V2, V3, sometimes out to V4. Massive PEs can produce ST elevation and depression. I never learned that before. They can mimic STEMI. And in particular, they tend to produce ST elevation in V1, V2, and even in AVR. You might remember we talked about ST elevation in AVR, and one of the causes I mentioned was massive PE. It produces signs of global cardiac ischemia. So you get ST elevation in AVR. Tachycardia, that's no surprise. New AFib, that might not be a surprise. And signs of right heart strain, which can be rightward axis, in other words, the big S wave in 1, and tall R wave in V1. Let me show you some examples. Now, these are not necessarily specific for PE, but the key point here is that if you ever have a PE, if you ever diagnose a PE and you see any of these, you need to really be worried. Because the literature says that if your PE patient has any of these findings, there's a very high likelihood that if your patient's not already unstable, they're going to go on to develop hemodynamic instability and have morbidity and mortality. These are prognostic findings of a massive PE. So you really need to worry about these, and you might even lower your threshold for talking to your consultants about giving thrombolytics or embolectomy for these patients, because these predict a bad in-hospital course. Let me show you some examples that we've seen. Take a look at this patient. Look in V1 and V2. There's ST elevation in V1 and V2 and big-time ST depressions out laterally and even out here in some of the inferior leads. This was diagnosed as a STEMI. The patient went to the cath lab. They squirted the dye, found clean coronaries. Fortunately, after the negative cath, they then did a CTA and found the massive PE. But this was a surprise to everybody because it's not well known that massive PEs can mimic STEMI with ST elevation, in particular in V1 and V2. And by the way, there's ST elevation in AVR as well. Here's another one. I think actually Haney took care of this patient. This was a patient that had a massive STEMI, and everything went right, Haney. I'm not going to throw you under the bus here, but everything. This patient, again, ST elevation in V1, a bit in V2. There's ST segment depression, a little bit out laterally, huge T wave inversions of V1, V2, V3, V4, and some flip T waves in 2, 3, and maybe a bit in AVF. So flip T waves in the inferior and anterior septal leads, some ST segment changes. A lot of people would look at that and say, my gosh, this person has ACS and they need to go for cath. No, think about PE as well. All right, when you see what appears to be ischemia on the 12 lead, a mistake that people make is that they tunnel vision and only think ACS. Please don't do that. There are a lot of deadly things that can produce ischemic findings on the 12 lead. ACS can, dissection can also, PE can do it, pericarditis, tamponade can do it. You know what? If you hook your, next time you have a slow shift, just have a little fun. Hook yourself up to the 12 lead and just purposely hyperventilate. And you'll flip your T waves. It's kind of neat. You'll pass out after that, but nevertheless, you'll have a cool EKG, all right? So hyperventilation can cause T wave inversions. Pulmonary problems can produce T wave inversions. Pulmonary problems, sometimes PEs, can produce ST segment changes as well. Here's another one. Once again, there's a little bit of ST elevation, V1, V2, a little elevation in AVR. You've got some ST segment depression in the inferior leads, ST depression out laterally. Ischemic findings. This was a massive PE. And this is a great case. This was from a number of years ago at a hospital, one of our affiliate hospitals. The patient came in with chest pain. Now, nobody really paid attention to the fact that it was chest pain of abrupt onset, right? MIs don't usually tend to present abruptly. If you really ask them, MIs tend to be crescendo over 10 minutes, 15 minutes. But this patient said the pain started like that. That's not an MI. That's PE or dissection. Think about those up first. Anyway, they got a 12 lead, not a great history, but they got a 12 lead, and the computer and the emergency physician and the interventional cardiologist looked at this and said, hey, this person's having a septal STEMI. So the patient went immediately to the cath lab and squirted the dye, and it was a normal cath, right? So what did they do? They stopped the heparin. They admitted the patient to the floor to complete the rule out, sandbag on the groin, everything's okay. Patient's no longer on heparin now. Why? They just ruled out. Now finish up getting the troponins. What should you do? Well, if you've got concerning chest pain and you've just ruled out ACS, your job's not done. Now you've got to think about all the other deadly causes of chest pain. But the mistake here is that they had tunnel vision, they saw ST segment changes, and suddenly they only thought, rule out MI. And then once they did that, they washed their hands and said, I'm done. No, what they should have done is said, rule out MI, done. Now I've got to think about other deadly, I've got to think about dissection, PE, pericarditis, and tamponade, because those can produce ischemic changes also. So anyway, the patient had a clean cath, got admitted to the floor. Plan was to just finish ruling him out. Next morning, after multiple negative troponins, the patient had a cardiac arrest and died. And an autopsy was found to have a massive PE, and nobody realized that the ST elevations could be caused by a PE. All right? And I've seen medical legal cases just like that as well, at least 2 cases. All right? One case, which was just flipped T waves. Patient got admitted, ruled out, got discharged home, and died. And after the patient got ruled out, they shouldn't have discharged. They should have said, all right, we've ruled out one of the deadly things. Now we've got to think about the other deadly things before that patient goes home. All right? The other one was a STEMI, just like this case. So, quick take-home points. PEs, please remember this. It's not commonly taught. But PEs are notorious for mimicking ACS. Not little PEs, big PEs are notorious for mimicking ACS. T-wave inversions are perhaps the most common abnormality in massive PEs, not tachycardia, but T-wave changes that mimic ACS. You can get ST segment changes, and what the literature is now showing is that when you have any ischemic-looking findings on the 12 lead of a PE, that portends an adverse prognosis. It portends a significant increase in morbidity and mortality, a significant increase in likelihood that the patient, if not already, they're going to become hemodynamically unstable and be defined a massive PE. So when you see a PE who's got any of those findings, you've really got to worry. No way is that person going home. In fact, I would argue, no way is that person being admitted to the floor. Those are patients that you should push to get up to the ICU based on no less than 5 articles, 6 articles actually now, in the past 2 years. All right? So be very careful about that. All right. So this was sent to me from Austin, Texas. I don't know if anyone's from Austin. I don't know what kind of picnics are down there. What I find most interesting also that here's under picnic supplies, there's batteries down here. I don't know how that relates to all the rest of this stuff. I don't want to go there. All right. So let's finish up with this case. All right. This was sent by some friends at LA County, actually. All right. Jan Schoenberger is the program director down there. Ariel is one of the residents, and Paul is one of the faculty up there. They had a 76-year-old woman who presented with 20 minutes of chest pain. The pain was very concerning, radiating to the neck, jaw, teeth, nausea, shortness of breath, diaphragms. This is a slam dunk admission. There's no way this patient's going home. Right? So 76 years old, we've already established one of the laws is the chance of discharge 100 minus age. So there's only a 24% likelihood she's going to go home just when she registers, right? She's staying with the chest pain and everything else. What else? History of diabetes, hypertension, hyperlipidemia. This is a slam dunk admission. If this patient was asymptomatic and came to my ED as a visitor, I'd admit her. All right? So 12-lead ECG, here you go. Now, we talked about left bundle yesterday, and I told you I'd talk a little bit about some new criteria here. Here's the patient. This is just a routine left bundle branch block, all right? There's no old ECGs for comparison. All right. Now, you recall yesterday I presented a newer algorithm. What we know now is that when patients come in with chest pain and a left bundle, you don't need to worry so much if it's a new or old left bundle. The new algorithm that's been published says the first thing you ask is, are they unstable? If they're unstable, push for cath. Or if they're in acute cardiogenic pulmonary edema, push for cath. This patient is neither of the above. She's stable and no pulmonary edema. Okay? Next step, look at the 12 lead now. And what you're going to look for is evidence of those Sgarbossa concordance criteria, Sgarbossa A or B. If yes, either of those, then cath. If no, then just do a routine rule out. So what are those Sgarbossa criteria? Again, the concordance criteria means Sgarbossa A, if this ST segment is elevated in the same direction as a QRS complex, that's considered positive. Sgarbossa B, if in V1, V2, or V3, if the ST segment is depressed at least a millimeter in the same direction as the QRS, then call it positive, you're done. Those are the 2 Sgarbossa concordance criteria. The third Sgarbossa criteria, which has been shown to be much less specific, so we don't pay much attention to it anymore, so I'm going to cross that out. Actually, I'll tell you what it was. No, I'll cross it out for now, and I'll tell you what it was a little bit later. So these are the 2 concordance criteria. And the other article, which is coming up in a second, has also endorsed this algorithm. Now, if you look back at this 12 lead initially, this patient has neither of those Sgarbossa criteria. There's no ST elevation in the same direction as the QRS. All right? QRS points up, there's no ST elevation. We're happy with that. QRS points up, there's no ST elevation. We're happy. QRS points up, there's no ST elevation. QRS points up, there's no ST elevation. So Sgarbossa A, no. What about Sgarbossa B? Sgarbossa B says in V1, V2, or V3, is there ST depression of at least 1 millimeter? Well, looking up here, V1, V2, V3, there's no ST depression. So this patient does not meet Sgarbossa A or Sgarbossa B. All right? So based on that algorithm, the patient doesn't meet criteria. Now, what about Sgarbossa C, the third criteria that I mentioned? Sgarbossa C says if the QRS is pointing down and there's ST elevation, normally that's good. But if the ST elevation is greater than 5 millimeters, that's too much. And that should make you concerned. Well, it turned out that when they studied this third criteria, it didn't tend to work out that well. But along came an emergency physician named Steve Smith, who works up at Hennepin, who said, well, you know, maybe this 5 millimeter rule, absolute 5 millimeters, doesn't work because we should be looking at the ratio of the ST elevation to the size of the QRS. Because, you know what, if a person's QRS complex is 100 millimeters, I'm exaggerating, but 100 millimeters, then a 5 millimeter elevation, that's nothing. That person's just got gigantic voltage. On the other hand, if the QRS complex is 10 millimeters going down with 5 millimeters of elevation, that's pretty significant. So maybe we should look at the ratio. So what he said is that if the ST elevation, if the ST segment heads in the opposite direction of the QRS by more than 25%, then you need to worry. All right, let's look at this visually, what he's saying. All right, what he said was, take a look up here. The QRS complex is 10 millimeters in height, and the ST deviation is 4 millimeters in the opposite direction. 4 is more than 25% of 10, so this would be positive for a STEMI. What if the QRS goes down? Well, here's a QRS that goes down 10 millimeters. The ST deviation's in the opposite direction, 3.2. That's 32%. 32% is more than 25. So this would be considered positive for a STEMI also. Does that make sense, hopefully? So if the ST segment is in the opposite direction more than 25% of the height of the main QRS, call it positive. So that's what he proposed and published in 2012. And this got incorporated into the other guideline I showed you yesterday that was published in American Heart Journal. Once again, when somebody's got a left bundle, first question, are they unstable or in pulmonary edema? If yes, cath. If not, look at Sgarbossa A and Sgarbossa B. If yes, cath. If no, then look at this 25% ratio business. Well, the validation study has now been published. And so now I would argue that this is ready for prime time. All right? Again, your cardiologist will probably not know about this because your cardiologists are not reading the EKG literature. They're reading other literature. This is what you and I have to be experts at. So get this article and share it with your cardiologist. So anyway, let's go back to the case here. All right? So this was the initial 12-lead EKG. What the physicians from LA County did was they repeated the EKG 20 minutes later. Here's the repeat. All right? And what we'll do is we'll just take V3, we'll blow it up, and take a look at what happened to V3 when they repeated the 12-lead. I'm going to blow this up. There's the main QRS complex. It's 16 millimeters in depth. The ST deviation is 5 millimeters in the opposite direction. That's more than 25%. So they call this positive based on the revised, validated Smith criteria. So they called up cardiology, activated the cath lab, and sure enough, a 100% LAD occlusion. That's a life saved. And had it not been for them knowing about this criteria, they would have just let that left bundle sit and infarct and infarct and infarct, and left bundles already have lost a lot of tissue. They don't do well when they infarct. So that's a life saved because they knew about this validated criteria, and they convinced their cardiologist to take this patient to the cath lab positive. All right, 2 days post-cath, there's new T-wave inversions, which are typical after cath, but you'll notice all of the Sgarbossa criteria are now gone because the patient has got a stent in there now. All right? So take-home points about left bundle and MI. Number one, you've got to know the Sgarbossa criteria. If you're not comfortable with it, Google search it, email me, I'll send you videos. This is something you as an emergency physician have to know. And you also have to be prepared to share this literature with your cardiologist because most of them are not reading the EKG literature. You have to be the expert at EKGs. All right? And even though this is not yet in the guidelines, I would argue that best practice dictates that Sgarbossa patients go for emergent cath, including the validated criteria. And if you get argument, that's why you've got to have this literature on hand and share it with your colleagues because they won't know about it. All right? And you're going to see more and more literature about this new validated criteria, and when it comes along, share it with your cardiologists. Okay? And again, here is the algorithm. Step number one, are they unstable or in pulmonary edema? If yes, the cardiology literature itself is saying push for cath. If they're stable, as this patient was, look for the Sgarbossa concordance criteria, Sgarbossa A or B. If yes, push for cath. If no, look for that new validated Smith criteria. ST deviation more than 25% in the opposite direction. If yes, push for cath. And this is one of those times where you're going to take the article and you're going to put it on the stretcher as they roll up to the cath lab. All right? Okay. So summarizing these last few articles, number one, be patient with your consultants and share the literature with them. You've got to do that. Don't ever assume that the other people have read the same stuff or gone to the same conferences you have. All right? You've got to share that literature with your colleagues in the ED, with your colleagues down the hall, with your colleagues upstairs. Don't assume that they know about that. All right? Presyncope equals syncope in terms of the etiologies and the workup. And finally, in PEs, remember PEs can mimic ACS, flip T waves, ST elevation, ST depression, ST elevation in AVR, right? And signs of right heart strain, tall R wave in AVR, these all predict impending hemodynamic instability. Be worried about those PE patients. And the corollary to that also is just because you see what looks like ischemia on the 12 lead doesn't mean that ischemia is the only thing you've got to rule out, because there's a lot of other dangerous things that mimic ischemia, most concerningly, PE, dissection, and pericarditis. All right? And then finally, know the Sgarbossa criteria, know this new revised Sgarbossa criteria. If you've got questions about this, just send me an email, and I'll be happy to share some of those videos, or just go on the internet. It's all over the internet. It should be all over the internet by now. With that, we're going to close things out. I'll be around for any questions, but on behalf of Teresa and me and Sujal and Diku and Haney and Mike Winters, I sincerely want to express my appreciation to all of you for coming out to Las Vegas and sharing your time with us. I hope you go back with at least a few pearls that are going to save lives. And I've really enjoyed talking to you all, interesting cases that you guys have presented. And I really hope you all come back next year. Thank you all and have a great evening. All right.